And I make that past, so if we can just start the meeting, I'll just remind everybody that the meeting is being recorded and placed on the websites of Dundee City Council and the Health and Social Care Partnership for public viewing. And I'll now take a roll call for the minute. Beth Hamilton.
Present.
I've had apologies from Councillor Lynn. Councillor Toland. Councillor McHugh.
Present.
Donald McPherson.
Present.
Sam Riddle.
Present.
Diane McCulloch.
Present, Arlene.
I've had apologies from Vicky Irons. Dave Berry.
Present, Arlene.
I've had apologies from David Wilson. Susie Flower. James Cotton. Raymond Marshall.
Present, thanks.
Jim McFarlane.
I'm here, Arlene, thanks.
Christina Cooper. Liz Goss.
Present.
Martin Sloan.
Present.
I've had apologies from Emma Fletcher. And finally, David Shaw.
Present.
That concludes the roll call. Thank you. Item 1.
Oh, I'm so sorry, Arlene. I'm just late. I'm so sorry. I couldn't get onto the computer. It's Siobhan.
Okay, thank you.
Thank you.
That takes us on to item 1, apologies which have been noted. Item 2, declaration of interest. Are there any declarations? Dave, you've got your hand up.
Yeah, sorry, I know I'll not be part of the debate, but I'm just saying I'm a patient of Park Avenue Medical Practice.
Okay, thank you. And that takes us on to item 3, appointment of voting member and position of chairperson. You're asked to note Beth Hamilton's appointment as voting member and chair of the IJB. Can this be noted? Thank you. And I'll now hand over to Beth as the chair for item 4.
Thank you very much, and it's a pleasure and a privilege to be the chair of the IJB, so I hope to be able to support the IJB as much as I personally can, and thank you for all your support in advance. So quickly moving on, it's really a one-item agenda apart from me. Dave, do you want to come in?
Yes, thanks, Beth. So I was just going to say that I think David Shaw is going to introduce this report today. So just when you're ready.
Yes. Yeah, it is a one-item agenda, and it's about. I'm going to hand straight over to David to talk about the primary care situation in Dundee. David, can I hand over to you?
Thank you very much. You've got a paper there with the agenda that describes the situation that we're currently reviewing at Park Avenue. Park Avenue is a very long established practice in central Dundee, in an area where there's historically always been a large number of GP surgeries and continues to be. So they've been operating for many years, initially I think with 3 partners. At one stage it went up to 4. Due to a process of retirements, it's gradually been coming down. Currently 2 partners, one of whom told us about a year ago that they were planning to retire. The practice has struggled to recruit over a fairly large number of years. We have assisted them by posting a career GP to add some resiliency to their team. They're currently on their 2nd cycle of a career start. So they've had 1 2-year post, and they're now midway through a 2nd 2-year posting to add additional resilience to the team. Practice have been active participants in trying to manage demands and have trained and appointed advanced nurse practitioners to try and assist with their patient numbers. See graphs within the paper that describe the practice list size over time. and I think one of the actions of the practice was to try and control list size when it appeared to be more than they could manage, and that's the reason why you see that dip there. So as I said, there's been active input by both the primary care department and Dundee Health and Social Care Partnership with full engagement with the practice. Now, as I said, one of the partners is due to retire shortly. They gave us a lot of notice that that was going to occur, and that left us in the very difficult situation that we had about 4,800 patients at that time. It's reduced slightly since, and one remaining partner who didn't wish to continue as a single-handed partner. That's very understandable. There's a general presumption against being single-handed, particularly with such a very high list size. The average Scottish list has been creeping up in recent years as it's been harder to recruit GPs into the profession. It used to historically sit a little bit below 1,500 patients per partner. It's now closer to 1,600 to 1,700, but 4,700 patients is certainly more than one partner would ordinarily be expected, and it would have a very, very significant failure risk associated with that. So I can absolutely understand that in the absence of the ability to recruit, that the two partners at that stage decided that they would terminate the contract at the retirement date of one of them, so at the point it would transition to be single-handed. Now, we were very keen to try and support the practice as best we could. We worked with them to see whether or not there were any ways of adding to their resiliency. We worked across both the Dundee Partnership and Primary Care Department to try and describe what might happen, and ultimately took that through an options appraisal exercise to try and make sure that we could get the best outcome for patients. And some of the outcomes we are seeking to achieve are listed there in the paper, but essentially it boils down to is we try to make sure that we have a GP for every patient, so that GP is close to where the patients are, that there isn't a unsustainable situation either in the practice or in the wider community. So these are the things that we're sort of taking into that process. The best thing would be if we could get the practice to continue as it was from a patient perspective, because that would mean that you were being looked after by the same clinical team. There are a variety of different ways in which that might have occurred. It might be that a tendering process might end up with somebody choosing to take on the practice, either as a standalone unit or as a merger with somebody else. And we explored that initially, and unfortunately, whilst we did get some notes of interest, none of those actually materialized in terms of a concrete proposal. So we had to put that one by its side. The other options there that were reviewed are listed in the paper, but essentially, again, they boil down to we could attempt to run the practice as an independent unit, as a 2C practice, one which where the health board chooses to operate the practice using salaried doctors who they employ directly in much the same way as we have chosen to do in Lochee and in Maryfield within Dundee. We have similar practices also in Brecon and in Arbroath at the Abbey practice there. We look very carefully at that. The difficulties that we foresaw with that, which again are listed in the paper, are about the sustainability of that model. It's a relatively small patient list size, and it would be very person dependent. We felt that there were significant sustainability issues with running with such a small business unit at a time that it's really quite difficult to recruit GPs. So we then moved to consider whether or not we could merge this practice fully with some of the existing 2C practices, taking on board the full clinical team. And the mechanics of that are we just simply don't have the space to run that within the footprint that we have elsewhere in Dundee. So there wasn't an easy solution to that. That then led us on to review whether there was any capacity to consider moving patients to practices that were closest to where they lived, using both the Health Board run 2C practices and those GMS practices, which I guess run themselves, to help to manage that so that patients went to where there was sufficient capacity to manage that patient load. As part of that exercise, we were actively involved with all the practices within Dundee, and we've reached out also to practices on the periphery of Dundee as well, to see whether there was capacity to do this. Now, we accompanied that by an effort to recruit to our 2C network, and the outcome of this is that it seems that there are sufficient spaces for all patients to move into practices that are local to where they live. And that's the reason why the recommendation in this paper is that we support a closure of the practice with ideally retention of the clinical staff, and a movement of patients to those practices that have capacity that are located nearby. So that's been a very quick route through where we have got to. Now, some points about process. The ultimate decision as to what happens to the practice sits with NHS Tayside, and it is a decision of the Director of Primary Care. Now, some people might ask, who is the Director of Primary Care? I have the sad news to tell you that unfortunately at the moment it is me. It's not specifically mentioned in the paper, but if you want to know who it is, as I said, currently it's myself. It used to be the Chief Officer of Angus, and I think currently that this is an area that's under active review, but I'm it just now. The purpose of coming to the IJB today is to consider the options and give appropriate advice. The IJB isn't being asked to make a decision to keep the practice open, to close the practice, to do anything else with the practice. It is to give its best advice. And following that advice, we will then discuss further within a wider system at the executive leadership team at NHS Tayside. So there'll be further advice sought there, and then following the receipt of all of that advice, a decision will be made. So just really to go over that, today's discussion is to get the best advice from the Integrated Joint Board as to what should be done with regards to Park Avenue's termination of contract, and that will be considered, and a final decision will be made out with the IJB. I'll pause for breath and see if anyone wishes to come in.
Okay, are there any questions, point of clarity to start with? Raymond.
Thanks, David. I suppose my questions obviously around the staff and the staff that are within the practice, because I think I don't want to think about. I think that suggestions 2C or not 2C. It's that kind of where do the staff go and what opportunities have we got for staff. I understand the part that there's a commitment there for any of the practice that they'll come on to, because we've already had notification within Tayside Health regarding the potential that the staff could come in for an ask around any potential post, but there's nothing in the paper that details the staff, because I don't want to go into the details on the meeting, but
sure,
I'd like to understand what's happening to the staff because of that part, because this is about a practice closing, entitlements to these staff in relation to the practice closing, and then their opportunities part. I don't want that to get confused with what the staff may be entitled to with around that practice closing. and the responsibilities that sit with the practice to resolve that. So I think that bit's missing a wee bit in the paper, but I'm happy to pick up a copy yourself or Sona for that.
Absolutely. I can sort of very briefly give a response to that if you wish. So the staff are employed by the partners. So they're not employed directly by NHS Tayside. There are attached staff, health visitors, district nurses, who are employed by NHS Taysides, and they're unaffected by this. There'll obviously need to be some work done in ensuring that those people who are currently in receipt of those services have a smooth transition to new teams, if that is the ultimate decision. And we are working with both the health visiting and district nursing service to ensure that that's done smoothly. But in terms of people who are not partners, they are employed by the partnership, by Park Avenue partnership, and therefore their direct contractual relationship is with Park Avenue. Now, we are very conscious that we do not wish to lose people, so we've discussed this with human resources in NHS Tayside, and we've had an agreement that people who are employed by Park Avenue will have some degree of priority when vacancies emerge. This is similar to an agreement that we reached with regard to the Rye Hill practice. And in short, if you are on the redeployment register, then you have the top level of priority. But below that, there is a level of priority that would attract to Park Avenue staff that puts them above those people who are not currently employed by NHS Tayside when being considered for any vacancy that exists. Now, a personal reflection, we have a shortage of skilled administrative staff within general practice, and I'm very hopeful that we should be able to identify slots for such staff, and that may be outside NHS Tayside direct employment and within GMS practices. So other practices may choose to take folk on. Some of the practices who are taking Park Avenue patients, should this proceed, are also likely to wish to recruit to that. So I can't give a definite assurance that all members of staff will be employed elsewhere, but I would say that they will certainly be given priority, and there is a need for their skills, and we would be working to try and retain them. Does that cover your point, Raymond?
Yeah, thanks, Stephen. So any support we can give will happily help for the staff.
Thank you.
Thank you. We've got a plethora now, so we'll start with Donald and then we'll move on to Liz and Siobhan, and I think Dorothy, did she come on as well there? So Donald.
Yep, thank you, Beth, and thank you, David. You know, as always, you've worked through the possible options, and you've set out the position very clearly for us. Unfortunately, I'm afraid it's a discussion that we hear just a bit all too often, and I know that's not any reflection on the work that you do, but rather just it's a bigger picture issue. Two questions I had really. The first one, you mentioned that you put the practice out to tender and that there were notes of interest, but then no one actually came through with an offer. So I suppose I'd be interested to know, did we reach out to any of the people who put in a note of interest to understand why they didn't follow through on that? So that was my first question. And the second question is more just about the wider resilience of practices within Dundee. As you say, if you distribute the Park Avenue patients to other practices, what is the consequence on them? Does it, in a way, to help to bolster their practice, or is it actually just making one of them the next domino to fall? So these were my 2 points. Thanks.
David, I'll take the other questions because they might be of a similar theme and it'll save you repeating yourself. So, Liz, do you want to come in with your question and then we'll go to Siobhan?
Okay, my question was about the patient group and how involved they've been in this option appraisal and how they've been communicated with, and are they aware this is happening? And also what choices might they have when it comes to dispersal, about which practices they go to. So just a general question about the patient group and how much they know and how involved they've been. Thank you.
Okay.
Okay, Siobhan, do you want to give your question?
Thank you. Yeah, kind of similar actually. I was just thinking in terms of how the management of the dispersal of patients, or we're kind of looked at 4.54 and it said that that some of them some other surgeries had capacity to take quite a few, but others might with extra staff. So I was just wondering how that is being managed in terms of staff capacity to take on those additional staff. I'm also wondering, and I know that you kind of had experience of this, Raiha, but I'm also wondering how the management of patient transfer, how you can facilitate that, especially for people with vulnerable medical conditions, and how you manage that transfer in a kind of in a seamless, kind of trauma-friendly way, if that makes sense.
Absolutely, it does, and we've got good responses, I think, to those, or at least I think they're good, but obviously I could be wrong. I've got a set of questions. I've been trying to note them down so I don't lose any of them as we go along. So I think, Donald, your first question was really about what we've done about reaching out to people who'd expressed some interest. Certainly, we did two sets of things. We had pretty frank discussions with practices about what contracting was about, how they could tender, what they could do about it. Tendering is a process whereby you can say that you will do a set of things for more than the notional value of the contract, which I guess in English means that it doesn't have to be the price that you would get at a dispersal. If you say you're going to do something extra, then potentially there's a way of shaping that so that it's quite attractive. We've successfully tendered the Whitfield practice, which then changed its name to Newfield, and that came with additional resource for a period of time. So we tried to make it as apparent as possible to independent contractors locally that they had the freedom to describe what they wanted to do. But I think nonetheless, they found the process difficult. We did follow up with them afterwards, and I think there are still a lot of uncertainties. It's a big risk, and people understand dispersal to a greater degree than they understand tendering. There's, I think, difficulties in terms of what we can and cannot say that are there for legal reasons. So you have to work within an envelope of information. But as I said, we are taking on board each time that we have unfortunately gone out to tendering, how we could make it easier, how it is we can support practices to do stuff that means that they might result in a better outcome. And we do have the example of a successful tender to show people, which may encourage, should we be in this situation again. You also raised a point about where does this leave Dundee in terms of resiliency. I think it would be foolish to say anything other than we are using up resiliency as we go along. If there is current capacity within practices to take patients and we move Park Avenue patients into that, then you are going to find that there is going to be a little bit less resiliency for the next patient who seeks to come along. So in terms of how to make sure that that doesn't have too destabilizing impacts, we don't want another domino. What is it we can do there? Well, we have worked specifically with those practices who have stated that they've got some degree of capacity to try and ensure that their resiliency is not diminished by too great an amount. We will be working with all practices over the period following any closure, if that is what the final outcome is, to try and ensure that we have a reduction in churn from practice to practice for a period of time, much as we have had since the closure of the Rye Hill practice. And we think that will probably help up to a point. We intend to come back to the IJB to seek additional funds to continue with the Career Start programme, which helped Park Avenue not be in the situation for about 3 years. So I think it did something useful, and I think there are other places where it has successfully averted this sort of problem. We've got positive examples of where practices have said, we think we may have to terminate, and they've not, because we've managed to support them. So as I said, I think there are specific positive steps that we can take from this. We have a resiliency survey that gets sent around to all practices across Tayside. We had all but one practice in Tayside complete that last year, and practices received their latest iteration of that survey yesterday. So in terms of mapping where problems exist, we have that to help us move forward. And there's an ambition to have a 6-monthly cycle of that survey go out, which should help to pinpoint areas where there are weaknesses. The nature of that survey is that it's reasonably granular in showing what kind of weaknesses exist, and there are certainly actions that practices can take, actions the primary care department can take, and actions that Dundee can take that will help to impact on that survey. These includes, for example, becoming a training practice, taking on FYs actively, upskilling the nursing cohort, and looking at access and other system processes within the practice. And we have a suite of these things that we discuss with practices, and many of them have taken on these actions as a result of that. So I think that's that element. You discussed patient communication and engagement. I think it's always very difficult when you have a decision about a termination of contract, because some of the things you might ask patients, like, do you want your practice to stay open or not? You're pretty damn sure what they're going to say. And unfortunately, their willingness to keep the practice open may not be matched by your ability to deliver that. Patient communication is very important. We have been closely in touch with the comms department, who, although Park Avenue is not directly run by NHS Tayside, are working closely with the practice to ensure that there's a single shared message, with communications between both NHS Tayside and Park being shared. So patients shouldn't be in the position where they're being told different things by different people. We will be sending letters out to patients following a decision that will go through next steps, what they can expect. We imagine that patients will largely go with the distribution, but as with previous practice closures, such as at Rye Hill, we did put out guidance to practices about treating people with compassion, and to take into account the specific nature of the vulnerabilities that they may show. For example, you've got a patient who is unable to get to an allocated surgery, but has a relative who can get them to a different one, then we would expect practices to work with that. And the guidance that goes out helps to support that. We want to do specific work with vulnerable patients. Patients can be vulnerable for all manner of different reasons. Sometimes it's because of age and infirmity. Sometimes it's because of mental health or other characteristics. So we want to set aside a bit of time thinking about how best that's handled. And as part of that, we are engaging with the practice for an additional 2 weeks after their contract termination date to try and make sure that we have an active handover of those patients who are perhaps midway through their treatment, who require to have some narrative about what their plans for the future are, who require a greater degree of handover of care. So there's an element that's set aside to try and deal with this. And as I've previously alluded to, we will be working with our health visiting community nursing colleagues to make sure that the teams who will adopt patients are aware of their needs and their requirements. So I don't think that's an ideal situation. None of this is ideal, but I think this is probably the most reasonable outcome that we can achieve. And as I said, communications will be coming shortly, but we don't want to communicate prior to certainty, and we will have certainty shortly. Next steps about redistribution, I think, was a bit. I think that's really about trying to work out where people go and make sure that we've got a clear process that supports the right people going to the right place. I've discussed elements of that in terms of trying to make sure that whilst there will be a process whereby I guess we allocate people to where there is capacity based on geography, there may need to be some give and take on that. There needs to be some operational work done, and there will be a small team encompassing Primary Care Department, Dundee Health and Social Care Partnership, and the practice to try and make sure that there is some more personal management of more complex issues that are likely to arise. So we will need to work through a variety of changes that take place at chemist contractors, where your medicines go to, what happens with prescription systems. We will need to work out whether or not we can put in additional input into practices that require some pharmacy support. We'll need to work out how to fund and staff that. So there will be a set of actions. We'll also be working with our IT colleagues to try and make sure that records are transferred as completely and as comprehensively as possible and within a sensible timescale so that patients' information travels with them. I think that covers most of the questions that were asked, but if people feel that I've left something hanging that they had asked, then I'd appreciate if you could tell me and I'll try and catch it up.
Dorothy, do you want to come in? Your hand was up and then went down again, but do you want to come in now?
Yes, I had questions earlier, but most of them seem to have been dealt with by other people's questions. I wondered, David, if we've had transfers and reallocation of patients when surgeries have closed previously. Do we have any information on the outcomes, you know, when we've done this previously, and you know, the kind of things that we need to be looking out for when it happens again? And the other tiny wee question I had was relating to the report on page 4. There's a chart 2 on page 4, and I really don't know what it's telling me.
Okay. Chart 2 on page 4 is a description of where patients live, broken down by localities. For example, Maryfields, I think there are 1,331 patients who live in that particular area. I guess what I would take from the chart is that whilst Park Avenue has got a very large practice area, it covers, I think, a wider area than almost any other practice in Dundee. The vast majority of patients are either in the city centre or towards the east end of the town. So I think that chart's really trying to tell you where patients are. Now, in terms of your other question there, we do a review after any closure to work out what worked, what didn't work, what we can learn from it. And there'll be a review after this as well. And unfortunately, we've had a few closures, and after each one, we troubleshoot and try and make sure that the processes are smoother the next time. I think specific things that we've learned have been about medications and how they're handled, what the messaging should be between practices, independent contractor pharmacies, NHS Tayside, what the content of letters to patients should contain, what additional information should be given to patients, what messaging should go out to other practices, what messaging should go out to other services. So I think I have absolutely no doubt that we will get lessons that come from Park Avenue in terms of how we can ensure that we have the best processes should we be in this situation again.
Thank you, David. David, there's one question I was hoping to ask. I noticed that it's the building itself is owned by the practice itself. Is there any opportunity that we could take the building and use it for other primary care based services, not necessarily GPs, but some other purpose? I know they were talking about that in other areas, that, you know, in a sub office you could develop maybe a practice nurses or, you know, a cane treatment.
We've certainly looked at the premises to see if there was an alternate use. I think there are elements with regard to the building that make it difficult to use for other partnership purposes. So I think whilst it might be available, I'm unclear that we have an active plan to use that. I'll let Shona come in at this point.
Thanks, Shona.
Yeah, I mean, it's an important point because we keep highlighting some of our capacity constraints because of not having suitable premises. But as David said earlier, I think the number of buildings in that area, much as there are constraints with those as well, we've got more significant gaps in other areas. So when we look at how we provide our services locally, we've done some mapping with care and treatment services, for example, Beth, which you raised, and we've got much bigger gaps in terms of people having access to services locally in the northeast and some of the other areas than we would in Stobswell, where we've got premises in Wallistown and Maryfield in particular that we're using. So yes, we've got issues, but we probably wouldn't necessarily physically meet the needs of what we were looking for. There's also obviously a financial implication of taking additional premises on as well.
Okay, that's great. Thank you very much. Any other points? Well, David, I think you've given us a pretty comprehensive overview. If there's no other points, I think we just need to agree that we note, I'm just the paper, that we note the current position with Park Avenue Medical Practice and the termination date of their GMS contract with NHS Tayside on the 12th of April 24. We note the options explored for ensuring ongoing care for those patients currently registered with Park Avenue Medical Practice. We note the preferred option is to disperse patients to other practices utilising the 2C network in Dundee and independent practices, and provide comment to the Director of Primary Care, NHS Tayside, to consider in the decision making. Can I get agreement, general agreement with that?
Yeah.
Yep. Okay, thank you. Thank you for that, David, and thank you for your colleagues and the work that you're doing.
Could I just be slightly picky? One of the things that I'm going to get asked the executive leadership team when we discuss this next week is the IJB supportive to the paper? So as I said, if there are any specific comments that you would want me to feedback from the IJB into that meeting, then it would be really appreciated to say whether you feel that this is something that the IJB has any specific issues that it would want to raise, whether they're broadly supportive of the process and outcome.
Okay, David, I think taking from the meeting, I would say yes, we are favourable of the recommendation, but I note that recommendation 2.4 was to provide comment to the Director of Primary Care to consider the decision making, and I think we will take that opportunity of gathering any specific comments and forward those to you in writing. Dorothy, you want to?
Yes, I did have one specific comment that I wasn't going to bother making, but I will. have a special interest in integrated impact assessments, as anyone who knows me on the council or the IJB will know. And I have actually raised this concern with Catherine because I believe there's to be a review of the operation of integrated impact assessments. So what concerns me is page 17 of the integrated impact assessment talks about socioeconomic disadvantage. And in every box, it says no known impact, and that's been interpreted as no impact. And the point I'm trying to make is if there's no known impact, that doesn't equate to no impact. That just means you don't know what the impacts are. So that should say not known and not no impact. So it's just a little thing, but it's one of the things that I think it's really important, particularly for voting members on these boards, to know the implications of any decisions that they're making, you know, good or bad. So if that's my only comment, David.
Dorothy, I think that's
useful.
Okay. So David, what I'll do is ask members of the committee to pass any comments on, and we'll collate them and get them to you to give you that supporting documentation for your meeting with the ELT.
Thank you very much indeed, Beth.
Thank you very much. Arlene, do you want me to hand back to you now for the next item?
Yeah, so the final item is just the date of the next meeting, which is Wednesday, the 21st of February at 10 o'clock.
Okay, that just leaves me to thank you all for your attendance, and I look forward to seeing you again on the 21st of February. Thank you.
Cheers.
Thanks, Beth. Bye.
Bye.